an other group which describes the private services. In terms of numbers, in the public services, we have 1,050 acute beds, 56 acute POA beds, and over 1,000 beds in 24-hour residences. And then we also have non-acute units that have about 719 persons. The source of that is the Mental Health Commission's report on beds that was published in February. We also have the forensic services with 103 beds, the child services and the private hospitals. And as you can see, they're divided out there with their bed numbers according to the Mental Health Commission reports that are available publicly. And you can see there's a high number of beds there, some of which are acute and some of which are long stay. Yes, in terms of mental health settings, our response in terms of COVID-19 will depend on a number of variables. So firstly, is it an acute unit where there's a lot of traffic? Is it a high observation unit where there's a level of acuity of mental health symptoms? Is it the Phoenix Centre, which will have quite severely ill people, but it's very roomy and has single rooms and a lot of space? Is it a rehabilitation ward that could be within a public service or in Highfield or Bloomfield? Is it a hostel? So the type of things that vary are single room layout versus multi-bedded rooms, and that can apply to acute units, hostels, and other units. Is there an ability to divide your unit in the event of an outbreak? And that's very important because, as we'll see, trying to prevent further infection and onward transmission of infection is key to managing. What are the staffing levels in each unit? What is the skill mix of that staffing? Is it, are there general nurses available in some units as well as psychiatric nurses? If it's an ID unit, and I know ID has been dealt with separately in webinars, but it's also relevant here, what's the skill mix there? What is the level of training of healthcare assistants? What's the level of training of the medical staff? These are all important considerations. And what equipment have you? Have you sets of equipment to test observations? Have you more than one thermometer, non-contact thermometer? Have you oxygen points in your unit, or are you reliant on cylinders? And how many cylinders would you have? Have you access to PPE? Will you have access to PPE going forward? What happens if the guidelines change around the use of PPE? These are all features that we need to bear in mind if we're going to be managing patients or an outbreak. And then the level of care that's reasonably possible in your unit. Can you give fluids? Can you give subcutaneous fluids? Is there some psychiatry unit that can actually give IV fluids? I think anecdotally there are. But it's not usual. Now, we have to be conscious of the age profile in our settings. A lot of people went to hostels 20, 30 years ago, and a lot of people have aged in situ. And these people will have aged at, maybe some have aged with very good mental health and very good physical health, and some may have a lot of comorbid problems. And for example, in hostel I'm looking after at the moment, with 10 beds, there's 4 over 70 and 3 over 60 and 2 over 50. And they have a variety of medical problems such as COPD, recurrent chest infections, diabetes, hypertension, cardiac disease, all of which are relevant in this setting. There was a census done by the HRB, who provide our 3-monthly stats, and they found that 5.3% of persons resident in our units were aged 65 and over on the night of the census, and 39% of those in independent and private charitable centres were also. But in the long-term care units, there's a considerable amount of people over 75. So we need to bear in mind about the morbidities of our population. It has been well known for years that people with mental illness suffer unduly from physical illnesses as well, and their survival rates are less than the general population. There was studies by Barraclough back many years ago that found that people died on average 10 to 15 years younger people with mental health problems, but they're dying mainly of natural diseases. So this particular slide by Hipsley Cox looked at the survival rates of people with major illnesses in people who had schizophrenia and those who hadn't, and it reads quite starkly there that the people who have schizophrenia or long-term mental illness are have less survival. And there are many reasons for this, some of which I discussed already, but also the prevalence of COPD and smoking and lack of opportunity to get other health care is very important. So in terms of what we have to do, we have to advocate for our people that they get appropriate health care at this time, depending on their physical needs. Now, in terms of the medical services that are available to us, there'll be a wide variety of services available. For example, in hostels, there will probably be access to a GP, and each resident will be registered on the GMS, and certainly there will be involvement, and the GPs will be involved doing the physicals every so many months. In some cases, there's access to the acute hospital system for blood results, and I know in Beaumont we log in, our people are registered on the Beaumont system, so if we take blood, we can get it back on the hospital system, which is very convenient. But obviously that won't be the case in a standalone unit that may have health links, but that may not. Is there a facility to do IVs? I've heard anecdotally from the faculty of POA, Psychiatry of Old Age, that some units have used IVs in recent times when they've had people sick. That's not possible in all places, and it would very much depend on the situation that you were in and on the skill set. Ability to give subcutaneous fluids, maybe that's something that we might be able to aspire to, especially if there's a difficulty getting access to hospitals for people, depending on if hospitals become very busy in the future. We need to have knowledge of the new early warning score and the ISPAR, which is a handover mechanism, and I suppose each unit needs to have an idea of whether they can manage that system, and will the person at the other end, say duty doctor or GP, receive the message and know what's being transmitted. So there's an educational piece there and a readiness piece. And then we have to consider the cover to our wards and units on call and at weekends, like who comes down and what staff are available. Yes, thank you. So currently the arrangements within the mental health services, they actually vary, but broadly speaking, there will be access to the health link system. Actually, I need the slide before that. Yes, so staff in the unit can arrange testing to the National Ambulance Service or via a trained staff member. Now this situation is varying and changing, and I've had experience of it changing quite rapidly over the last week or so. So it's important that each unit would know how they are to get testing at present. Now, broadly speaking, a lot of persons with COVID-19 will be manageable in their current setting, and that should be the aim if possible. In terms of maybe people who have a positive swab, they can be isolated locally and that illness can be managed, because we have to bear in mind that a large number of people will have a relatively mild illness. So managing that will depend on symptoms and on the circumstances of the unit. People need access to appropriate medical management of their COVID-19 as of now, and we seem to be in the position at the moment where there is no overload in general hospitals. So Rory will deal with these issues in the third talk. The isolation is set that people who are COVID positive should remain in isolation for 14 days from the first onset of symptoms and must be fever-free for the last 5 days. Priority will be given to various persons according to whether they fit into various groups or not. So close contacts of a confirmed case will be a priority for testing. Also healthcare workers who are front-facing, I mean, people who are actually working with people, such as the nurses and the HCAs and the attending medical staff. People who have illnesses, and we have to be mindful that some people with illnesses, particularly in the elderly, there can be atypical presentations of COVID, and it can present as people just being a little bit more lethargic or more off than usual. Could be confusion, could be diarrhea, could be lethargy. So chronic lung disease, chronic heart disease, chronic renal disease, chronic liver disease, and smokers, they will be prioritised for testing, and their household contacts. And then outside of our own service, other groups are prioritised, such as Roma, travelling community, and places where symptom management is difficult. That would also include the homeless, prison staff and inmates, and people who are expecting babies. The next slide is a busy slide about testing. So yeah, so it's even quite small for me to see at the moment. But basically, there is a pathway that has been devised for referring for testing, but again, it's variable according to place. There is if people have access to HealthLink, it can be quite straightforward, but we also have access to the National Ambulance Service. There's also a plan to have each CHO have a pathway to get around not having health links. But I think the essential feature is that every unit in every CHO needs to know what they're going to have to do to get testing at a particular point in time, particularly going into a weekend. So make a plan on a Friday as to what will happen over a weekend if somebody needs to be tested. Okay. Thank you. That's the end of my presentation.
Oh, sorry about that. I was on mute. Hi everyone. My name is Mairead Kelly, and I'm the Assistant Director of Nursing in the Jonathan Swift Clinic, which is the approved centre in the St James's Hospital campus. I'm just going to talk to you for about 5 minutes, just give you an overview of the Jonathan Swift Clinic and its layout, and tell you how we were affected by COVID and what we did and what lessons we learned. So the Jonathan Swift Clinic, as I said, is the approved centre within the St James's Hospital campus, and we have 3 wards. We have a 22-bedded acute admission ward, which has 6 single rooms, but just 2 of those single rooms are ensuite rooms. We have a 16-bedded step-down ward, and it doesn't have any single rooms. We have a 9-bedded psychiatry of later life ward, which has 3 single rooms, and none of those are ensuite. Also within the campus, there's an acute day hospital, which is quite a small day hospital. It serves 2 sector teams, and there's just 1 office, so there's a lot of staff in and out of that office. Next slide, please. Thanks. So I suppose our story, or how we were affected, I suppose, from a staffing point of view, it all started for us on the 12th of March when our first staff member tested positive, and by the 24th of March we had 41 staff in isolation. 34 of the staff were tested, 13 tested positive, and of those 13, 8 were from the same team. So we had 30% of our staff in self-isolation at that stage. Okay, so then from a patient point of view, we had 7 patients who tested positive. 6 of the patients were from the psychiatry of later life ward. 5 of those patients ended up being transferred to the medical hospital in St James's, and 1 of the patients who was positive from the PLL ward remained in the Jonathan Swift. We were very fortunate that all the patients had good outcomes, and currently we have no COVID positive patients within the unit. So I suppose what we did and what we learned, I suppose, as we all know now at this stage, social distancing is really, really important. But I suppose, you know, at the time when our first staff member became positive, restaurants, bars were still open at that stage. Staff were still dining together, sharing food, and team meetings were happening where, you know, everyone was in one room in close proximity to one another. So I suppose now ward rounds are happening through Zoom. The patient groups had stopped for a while, but they're up and running again, but just with smaller members to maintain the social distancing. Isolate early. So I suppose that was really important as well. I suppose we had a couple of staff members that maybe one reported having a tickly throat, another said they had a slight cough, another said that, you know, they had felt unwell a couple of days earlier, but that they were fine now, and 2 of those 3 people tested positive. So that really, I suppose, brought home to us that, you know, if anyone has any slight symptoms, that they, you know, that they should isolate really quickly and get in touch with occupational health for advice. We were closed to visiting. Patients' leave was curtailed. We were closed to admissions and monitoring of symptoms. So I suppose, as Mary had said earlier on, not everyone was presenting with, you know, the classic symptoms of the sore throat, the high temperature and the cough. and 2 of our patients that tested positive, their first symptom was actually nausea and vomiting. So we were observing all the patients and observing their observations on a twice daily basis. So we were checking temperature, checking BP, and checking oxygen sats. And I suppose we were also observing and asking them about other symptoms. You know, had they a sore throat, had they a cough, etc. Any patients that were positive, then we were checking their obs on a 4 daily basis. And when we were lucky that we had close links with the general hospital, so if somebody did deteriorate medically, they were transferred over to the general hospital quite quickly. And mostly what we saw when people were deteriorating was that their oxygen levels were dropping. So seeking advice, I suppose when we were going to reopen, then when things were improving for us, we got advice from the infectious diseases team in St. James's, just around reducing bed capacity so that we could maintain social distance for the patients, and also around admission procedure. So for the moment, where anyone that's coming in for admission from the community, they're in isolation for 48 hours so that we can observe for symptoms and that we can arrange for testing if it's needed. Also, I suppose just to say that we had redeployed a lot of our staff from the community, and those staff stayed within the inpatient unit. They didn't go from the inpatient unit back out to the community again, so as not to risk cross-contamination. And clinical governance, I suppose, on a daily basis initially, we had teleconference calls with senior management so that we could discuss any issues that were happening, and then keeping staff informed as well, just, you know, on a daily basis after those telecalls, if there was anything new, any developments, so that, you know, everybody was aware. And I suppose then about coming up with new methods of working. Staff, as I said earlier, the ward rounds are happening through Zoom. The inpatient groups, there's reduced numbers. Some staff some patients are having meals by their bedside, and, you know, in the dining rooms if social distancing can be maintained. Staff are also wearing masks if they can't maintain the 2-meter social distance. And that's it for me. That's the end of my presentation. Thank you.
Right, listen, I won't keep you. I'm Rory O'Donnell. I'm a chest physician in James's. Can you all hear me? Yes? Yes, good. I'm going to go through a few basics of COVID. And some of this you're going to know already, and some of it you won't, and some of it you don't need to know. But I'd be pretty quick to allow for time for questions. Number one, you'll see the slide. I brought up the HSE definition of a COVID case. Now, if you just read that, you'll see that in each one, it says a patient with acute respiratory illness. So you can stop reading there, okay? So when it says, or a patient with an acute respiratory illness who's been in contact with somebody, or a patient with an acute respiratory illness who's got shortness of breath, it doesn't matter. Everybody with an acute respiratory illness is COVID until proven otherwise at the moment, okay? It's all you need to know. If they're chesty or if they've got a new temperature, whatever it is, it's COVID until proven otherwise. Next slide. Okay, a few things you know. COVID, the reason for isolation, self-isolation for 14 days is that incubation period is variable, okay? So some people will incubate the virus within a couple of days, some people it takes a few weeks. So that's the reason for that. Next point, some patients will be asymptomatic, ergo it's possible to have COVID and have no symptoms whatsoever, but still be infective to others. Most patients will get classical symptoms, and the classical symptoms, can you go to the next slide, Laura, for a sec? Classical symptoms are on the left, your typical flu, your cough, myalgia, fatigue, fever, whatever it is. But there's a lot of atypical symptoms, and in particular in the elderly we're seeing diarrhea, nausea, vomiting, even difficulty swallowing, chest pain, and sometimes just delirium and confusion. Can you go back up one slide, Laura? So in patients with typical symptoms, yes, that's not going to take too much figuring out. They're going to need to be tested. In patients with atypical symptoms, you just need to have an open mind. And the way we're approaching it now, and the way James's A&E is approaching it, is anything can be COVID until proven otherwise. Now that's not always a good approach. For example, at the weekend we had a lady in with cellulitis of her leg and they swabbed her for COVID, and that was a waste of time and a waste of money, but you know, they're erring on the side of caution, because if she did have COVID and she infected the rest of the hospital, that wouldn't be good. So atypical symptoms, there's a very long list. Just be aware that COVID can do this. In patients in particular who have intellectual disability or who have dementia, as you well know, you might not have symptoms. There might not be even the ability to tell us that they've got a sore throat or cough or whatever. So very often we're reliant on the views of the carers, whether the patient is just not himself or drowsy or in poor form, because they can't enunciate that they're having problems. So again, a high level of suspicion and temperature checks are everything. So again, if you've got somebody, for example, who has severe Down syndrome and you do a temperature check and it's high, at the minute, that's COVID until proven otherwise. Okay. The majority of patients with COVID, as you know, get better and it's fine. Next slide, Laura. And next slide. A minority get this. So this is two X-rays from the same patient, and the big white thing in the middle is the heart, but the two black areas are the lungs, and the X-ray on the left is from, I think, Wednesday, and the X-ray on the right is from the following Saturday. So bilateral pneumonitis, an ARDS picture, and essentially what this X-ray means is that this patient's lungs are inflamed and not functioning properly. And that's the classic thing that you'll see in COVID, but not all COVIDs. Some will have it worse and some will have it better than that. Next slide. Next slide, Laura. Next slide. Going backwards. So the other thing to say about COVID is that, and I know this is all over the media, but it's an unforgiving illness. So we're well used to looking after patients with pneumonia, and pneumonia is one of the biggest killers of all of us. So if you live long enough and you don't have cancer or cardiovascular disease, it is very likely you'll die of pneumonia. And the thing about pneumonia is, if a patient has it, they don't tend to die right away. And I'm being very frank. There tends to be time, time where you can see them getting worse, time where you can intervene. And very many patients will, if they feel a bit chesty, they'll give it a day or two. They'll just sit on it for a day or two because they don't want to come to the hospital, etc. And very often, that's a reasonable thing to do. In COVID, it is not a reasonable thing to do. We've had patients who have been chesty on the Tuesday and who've been dead by the Wednesday evening. So it's very progressive, and very quickly progressive. So if your patient who you think has COVID has chest symptoms at all, and they are for full resuscitation and hospitalization, they need to be in the hospital. Okay, I wouldn't wait around like we often do with other forms of pneumonia. A minority of patients with COVID will get other things apart from their chest. They'll get sepsis, renal failure, cardiac failure. All of these things equal hospitalization, again, unless there's a very clear end-of-life plan made in the community. Next slide, Laura. So I'm not showing you this to annoy you. I'm showing you this to show this is the hospital pathway for patients with COVID. Now, it looks complicated, but look, for your interest, look at the column on the left where it says discharge criteria, okay? That's the only column I think that you need to be aware of right now. And you can see we have some criteria that will tell us it's okay to send a suspected patient with COVID home, okay? And if you read them, they make sense, but they would apply as well to patients who are in the psychiatric community in residential homes. That, the patient has to be well, their oxygen saturations have to be normal, their X-ray has to be clear, but the key things are 6 and 7. Number 7, they have to be able to self-isolate. So in other words, we are admitting patients to James's who are well, but they cannot self-isolate. Now that's not ideal, as you can imagine. It's a bad use of a hospital bed, but sometimes we've no choice until something else is sorted out. Ergo, if you have a patient in the community who cannot self-isolate, you need to get them out of there. Okay. Number 6 is the other thing, comorbidities. So patients who've got long-term disease, whether it's diabetes or COPD or heart failure or dementia, they've got to be in the hospital. You can't send that person home. I know that sounds like sounds like what you'd expect, but we are admitting patients to the hospital for social reasons with COVID, if they simply are not able to self-care for themselves. That, again, will apply to a lot of patients in the psychiatric community or with intellectual disability. If you ask yourself that one question, is this person able to self-isolate? Has this person got significant comorbidities? If the answer is yes, your decision is very easy. You have to refer them in. Okay, I'm going to ignore the rest of this slide. The rest of the slide is for what happens in hospital. So I'll give it to you in 2 sentences. By far the most important test we can do is their oxygen saturations. Okay, acceptable oxygen saturations are greater than 93%. Okay, less than 93% means you're in trouble, you may need oxygen, hospitalization, etc. We'll get on to that. Next slide. So again, this is the HSE slide, and I'm not going to go through it in detail, but it's a very wordy slide, but I'm going to take it apart in 3 sentences. Essentially, it gives the definition of COVID, and there's a lot of and or others. You can replace that with sick patient, okay? Sick patient, whatever it is, think COVID. If it's not COVID, good enough, but it could be, think of it as a possibility. If they cannot self-isolate or if they've got comorbidities, they tend to get admitted. If, however, you've got somebody who's functioning well in the community and is reliable and has no symptoms, they can be referred to GP or for local testing. Okay, this is going to sound like common sense, but this is where we're at. Ask yourself these questions. You know, are they sick? Ask yourself what you would normally do. Now, I can tell you, and I'm sure you know this, that there are no blanket decrees about resuscitation for patients with COVID. And you know, we're the chest service. The hospital here has over 100 COVID patients, and we refer to ICU. And so what happens in practice is there's a discussion about each patient, whether they should go to ICU or not, and the patient is judged based on what's appropriate, whether it's appropriate for them to be in ICU. So there are no blanket decrees at all. But there are patients that you can well imagine that the discussion probably doesn't need to take place because common sense would apply. But what happens in practice is we think about it. So even if I've got an 88-year-old person with severe dementia, I'm going to make a decision on that. There is no blanket decree for anyone, okay? Or a patient with Down syndrome, there is no blanket decree. Each patient is considered based on what is felt to be most appropriate. So we advocate for those patients while they're here. And I know that you do too. Ask yourself, is the patient a risk to others? Is the patient reliable? So, you know, if you have a patient and you feel that they're not reliable to self-isolate, it is what it is. We had a patient from Jonathan Swift who had COVID. She was entirely well, but she couldn't be relied upon to self-isolate. Okay, and the last point is the main one. You know, if you're not sure what to do, seek advice. That's what we do. So we have a confab here every morning at 8 o'clock, and we talk about the patients that came in the night before, and we make some decisions. So there's nobody, I could drag one of the ICU physicians down here now, but there is nobody who knows everything about everything. It's always good to discuss. So if you're concerned, have a quick chat with somebody about it, whether it's the GP or one of ourselves. This is just to help. Ask yourself these questions, and if you're getting an answer that I've highlighted in red, you need to consider hospitalization, okay? So if you've got somebody who's well, I'm talking about patients now that are diagnosed with COVID or suspected COVID. If they're well, they're reliable. When I say reliable, that they can self-isolate and look after themselves, that they've no morbidities, that person doesn't need to be here. But if you've got somebody who is sick and has no end-of-life care plan, they need to be in hospital. Now, you might have to make an end-of-life care plan there and then with the patient and with the patient's family, and that might be the appropriate thing to do. But if there isn't one, or if the family are saying, we're not happy, you've got to refer. And at the weekend again, we got a gentleman who was in a nursing home, who had dementia, who was 93 years old, and he ended up being referred to James's because his family were not comfortable with him dying in the nursing home. And we took him, you know. So nobody's going to get turned away. It's difficult. He died with us, you know, but at least he was palliated. So what I'm saying is, if any of the things that I've highlighted in red exist with that patient, you've got to consider hospital referral. Next slide. Okay, treatments. There's actually very little. Okay, because there's very little you can actually do. It's like having the flu. You can take your paracetamol, keep hydrated, plenty of oral fluids. That's about it. Okay, so if I was asked during the week about oxygen, oxygen, folks, you know that oxygen is a hospital drug. All right, that there are patients in the community on oxygen, but they're on very low flow oxygen. They're on 24% oxygen. At the most 28% oxygen, okay? So we're currently breathing now 21%, okay? So patients on home oxygen are on a little bit more oxygen than the rest of us, but not much. Patients who have COVID and are short of breath might need 60%, 100% oxygen. They might need high flow oxygen, none of which can actually be provided in the community. The equipment isn't there. The nursing homes are not supplied with oxygen to provide it. So if you've got a patient who needs oxygen and who does not have an end-of-life care plan that involves them, you know, being palliated, they need to be in hospital. Very straightforward. Okay, I'm gonna shut up now in case there's any questions. I could go on and on. I'll stop. Okay, so I'll mute myself again.
Thank you very much, Rory. I just to have the list of guidance documents in case anyone wants them, but we can be open to questions now. Karen or Kathy? Sorry, Kathy.
I'd like to introduce you to the panel who are on the call today. So we have Dr. Mary Cosgrove, who's a consultant psychiatrist, North Dublin Mental Health Services, and Maria Kelly, who's Assistant Director of Nursing for the Jonathan Swift Centre, St James's Hospital, Dr. Rory O'Donnell, Consultant Respiratory Physician at St James's Hospital. And then joining them on the panel today, we have Dr. Evan Jacob, Consultant Psychiatrist, Brothers of Charity Services Ireland, Oliver Myrna, Area Director of Nursing, Dublin South Central Mental Health Services, Dr. Sinead Reynolds, who's the General Manager, HSC Mental Health Operations and Performance, Evelyn Casey, Lead for National Deteriorating Patient Recognition and Response Improvement Programme, and Linda Moore, the Quality Compliance and Standards Officer, Quality and Service User Safety Community Healthcare, and I apologise if I pronounced anybody's name wrong. So what I'd like to do is to move then to some of the questions that were submitted ahead of the session today. And I'd like to start actually with Evelyn Casey, because I know that she has to leave a little early today. So I was just wanting to ask Evelyn, there's been a couple of questions that have been coming in specifically about the news track and trigger tool being used as an adjunct to clinical judgment. If you could maybe give a little bit of an explanation on that, Evelyn.
I suppose, okay, can you hear me, yeah?
Yeah.
Yeah, okay. So I suppose the news track and trigger it can only be used as an adjunct. So it isn't that, you know, you use your clinical judgment, you know, solely by itself. The track and trigger is intended only to be used with clinical judgment. So it isn't a defining piece. You have to use your clinical judgment aside with it. So it's not a case of using it in isolation. I suppose what I'd say about the track and triggers tool is if a score is high, and if that's a patient's baseline, which I know is some of the questions that have come in, if the score is higher
that's a new baseline being created, and you need to refer the patient. If they have normally a high baseline, that's something that needs to be worked out and looked at, and you refer to your medical supports. And what you can change is the escalation and response to meet that person's need. But you can't change the score. A few people have asked about changing the score and asked about changing the parameters. In the guideline, there's a guidance in the guideline, the NCEC guideline, is that you must not change the score or the parameters. What you can change is the escalation and response. Most people, if they have an increasing score, they need medical referral, and particularly in the just as the previous consultant talked about, in the context of COVID, they need referral to be seen medically or for a plan of care to be done. If they normally have a high baseline because of their comorbidities, you then need to have your escalation and response protocol for what are you going to do, how are you going to recognise when they're deteriorating.
Okay, thank you. And just another question to yourself, and also possibly to Dr. O'Donnell, around protocols for using oxygen. So the use of oxygen, I think specifically to do with patients who are maybe tested positive for COVID, and what's the evidence around it, and what should be, what's the advice?
Well, I think Dr. O'Donnell answered that very well in his presentation. I think he covered that pretty well in that, and I wouldn't have anything to add to that.
Well, very, very briefly, I did tell you that there's a bit of a mystery about oxygen out there. You can't give someone oxygen unless you can measure their oxygen. I mean, you can, but you don't know what you're doing. So oxygen, is not used in the community much at all. There's only it's used in patients with COPD. It's used sometimes in patients in palliative care where they benefit symptomatically from oxygen. But you can't look at a patient in a residential home and decide if they need oxygen or not. And you can't give them oxygen because you don't know how much they need. So, you need to be able to look at their oxygen saturations, and then you judge how much oxygen to give according to that. So there's no magic number. So if you've got a patient who is hypoxic, yes, they may look cyanosed, but you don't know how hypoxic they are. You don't know how much oxygen to give them. If they need oxygen, they need to be in a hospital setting, unfortunately. I don't know, does anyone disagree with that? The only maybe exception to that is if you have an elderly person who has their own oxygen at home already because they've got COPD or perhaps heart failure, it's reasonable to give them their own oxygen, but as part of palliation. And so, sometimes, to be honest, it's really so that patients and their families feel everything has been done. It's really worthless in terms of helping the patient. So if they need oxygen, they need to be in hospital.
I think you've probably covered this already quite well, but just any other comment you might have around criteria for transfer into acute services or for transfer into the general hospitals at the moment?
So in a very long, the HSE is coming out with criteria all the time. But to be honest, it comes down to what does common sense tell you, and what does your gut tell you. Like in most sort of residential homes, the carers there will know the patient very well, and they'll know if that patient is off, is unwell. It depends on how communicative the patient is. So if the main criteria for transfer to hospital is, one, if they're sick, okay? And I don't mean that, I mean if they've got sick in the same way as they might have the flu. You can't chance it. I don't think you can chance it if that patient is for full resuscitation and they're sick and they're not able to self-report their symptoms. I think they need to be referred, even if they're not breathless. And, so sometimes you might say, well, is it appropriate to do that? Sometimes, so what if it isn't? The worst thing that can happen is that the patient will be sent back. I think you're better to refer the patient, or at least seek advice on the patient first, And anyone who's sick who turns up at St. James's is going to get admitted, regardless of their underlying condition. It's almost impossible for us to send someone back, because even if they're for palliation, they may not have a palliative process in place wherever they're living, so we tend to keep.
Thank you. And maybe following on from that, Dr. Cosgrove, around the, I suppose, the anxieties that many staff have about blanket decisions being made regarding patients with, who have mental health issues, and how we ensure that there aren't these blanket decisions made regarding those patients from your services, and how they're treated in this at this time.
Well, I think it's very important that the management team of all services, mental health services, would be in agreement that they would advocate at all levels for patients to be treated just as Rory has outlined. I think that's key. Now, we can advocate above that in terms of professional groups such as the Irish Gerontological Society, where Dr. Diarmuid O'Shea has been issuing messages on an ongoing basis that are really helpful, or the College of Physicians, or the College of Psychiatry, the Irish College of Psychiatry. So I think they will consider issuing a message. But when it comes down to individual teams looking after patients, we must know, have a good idea of what our medical issues our patients have, and be in touch with their places of residence, their GPs, and be willing to send them and to fight for them, in terms of if there's phone calls and that. And I think that's how we make sure we can't hide from it if we're responsible for patients or residents. We must know, and we must expect a level of support in all hospitals, like what Rory is describing. And I think that's the key. But I suppose I'd focus on the management team of a service being aware that we're not 55 steps behind where we thought we'd be with hospitals overrun. So it is essential business as usual and advocate.
Thank you. And I guess there's some fear as well. Obviously, for the majority of people who are being looked after in the community, we're talking about people in their own homes. These are people living in medium low care residential hostel units, or sort of living in sort of sheltered accommodation, and how we protect the staff and how we best support the clients in these situations, because it feels like a very different world at the moment from the staff's perspective.
Yes, I think the most difficult situation would be if, say, a high support hospital where there would be nursing staff, maybe 2 staff at all times, if there were a proposal to send somebody back for palliative care. I think the readiness of that unit would have to be very much examined. And I have a couple of hospitals that I look after at the moment where I don't think they'd be able to do that. I don't think it would be fair to ask them. So so we do need to be conscious of the levels of care that we can support in a hospital, even if it has single rooms, for example.
I would add, that from our perspective, if we've got a patient and we think they need to go back to their nursing home or their residential home or their hostel, all it takes to stop that is a phone call. In other words, if someone rings me up and says, look, we can't take, this patient back because we can't palliate him, it's over. There's no argument. It would have been, it's incumbent on us to have asked the question first. So you should not fear having, if a patient is referred back for, say, palliative management, it is incumbent on us to ensure that you've got such a system in place, or a palliative care service who are happy to take it on, and nurses who are happy to take it on. And if the answer is no, they should not be sent back. Simple as.
Thank you. I know that there will be a specific seminar that is happening on Friday looking more at infection control, but I think it would be helpful maybe at this stage to answer one question that has come in specifically about, and this is to Linda Moore. Apologies, somebody started DIY outside my window. How to manage residents with no ensuite facilities and who share a bathroom in the event of a COVID positive case within a residential care setting.
So, will I take that? So if you've got a COVID positive case, then in theory, everyone else is at risk of infection. So that person, in theory, should be isolated from everybody and should not share a bathroom with anyone. There's no other way of doing it. Like there's nothing that I can say that will mitigate sharing a bathroom, except there will be this uncertainty. You know, if the COVID patient has been sharing a bathroom and maybe sharing a room with another patient, they've probably got it already. They probably have. But the best advice is that person is completely isolated from everybody. It's not, I know that's possibly impossible, do you know what I mean? But that's the only advice I can give you that's worth its salt, even though it may not be doable.
And Kathy, we've been suggesting that maybe services start as part of the preparedness plan to look at use of commodes, to use, you know, that so that they have these in place if they do need to, so that person can be isolated in their rooms. And the webinar will cover how to clean such equipment, where to store it, all of that. So they need to consider it now and not, oh, we've got a positive patient, how do we not let them use the bathroom?
Yeah. And I think there's a lot of mixed messaging coming out possibly as well from the UK around to wear a mask, to not wear a mask, when do you wear masks, should you wear masks all the time, and in doing so, is that effective? And I'm guessing this is the sort of thing we'll be covering on Friday as well.
Yes, and there's new guidance from the HPSC today in relation to masks. So that will be updated on the website. I think it's going up tomorrow. So we'll make sure that's sent out to our mental health services as well in relation to masks.
Super, thank you. There's been a couple of queries that have come in around testing, specifically how you might look for sort of these atypical symptoms and how reliable the testing actually is. You know, so if a patient really does seem to have symptoms but the test is negative, can you assume that a negative test equals that person does not definitely have COVID, or what you should do, I guess, as a service? So
the figure that was quoted to me is 80%. So the tests are 80% sensitive. Ergo, there will be 20% false negatives. So what we have been doing, again, is if we've got somebody who we think is COVID and their swab is negative, we're re-swabbing them. And that's happened a few times. Even over the last weekend, it's happened a few times. So if you have an index of suspicion and the COVID swab is negative, you need to get them swabbed again. Simple as that. It's pain, it's labor intensive, it's difficult, but it's got to be done. If you have a patient where there's an obvious other cause of their symptoms, for example, the lady we had at the weekend with cellulitis, I would only swab that person once, do you know? Like, if there's a patient whose symptoms cannot be explained by anything else, you've got to swab them twice.
Thank you. And that was a kind of a question that came in as well around the testing and the speediness with which testing is happening, because maybe someone is being isolated and being swabbed, and almost the isolation period is over before the swab test is likely to come back. Sort of any thoughts on that?
Well, according to the, so I know there was a big backlog of testing, I know that, but apparently that's supposed to be dealt with now. And according to the HSE guidance, anyone in a priority group should be swabbed urgently, and the results should be back urgently. And priority group includes anyone in residential accommodation. It includes people with comorbidities, etc., etc. But I would have thought a priority group would include anyone who falls under psychiatric services, unless they're extremely well, extremely well functioning in the community. So priority groups are supposed to get swabbed quickly. The GPs are supposed to be able to refer quickly via health link to one of the 46 centres, and they're supposed to be done within a day or two. The results, I don't know why the results are taking longer. The results in the hospital here, we have our results back on the same day. So I can't speak to that in the community, I don't know.
Okay. I'm wondering if I could ask Dr. Jacob, and apologies if that's a mispronunciation, just a couple of queries that came in around the use of telemedicine within mental health services, obviously where people are trying to avoid unnecessary exposures and sort of an unnecessary amount of contact. So around sort of use of telemedicine, and is it happening within mental health services at the moment? The use of Zoom, is it something that people are thinking sort of using it clinically, but then are there risks associated with that? Is it secure enough to do those sorts of clinical reviews on, or just your thoughts on that?
Yeah, so I suppose initially Blue Eye was rolled out as a platform for delivering telemedicine in terms of clinical consultations. And I think one of the difficulties with Blue Eye has been its patchy coverage. So in some areas it's worked quite well. In some areas it's hit issues with firewalls. And I think that there is still a working group chaired by Dr. Anne Jeffers, which is looking at ensuring that its coverage is rolled out as much as possible for people. The plan is to roll out a new platform called Attend Anywhere, which will be going live in the next few days, I think. The difficulty is for people, and that's where platforms like Zoom and Doxy.me have come in, is in those areas where there has been difficulties in the coverage with Blue Eye, and in the interim whilst Attend Anywhere is being rolled out, there's been this vacuum and people have had to be very pragmatic around filling it. And there's usually a sort of a link person per CHO that people have been consulting with, and some of the advice is included that being aware of some of the privacy issues in platforms like Zoom and WhatsApp and Doxy.me, but ultimately there's a kind of a risk assessment to be done in that if you're not going to use some of these platforms, and this will mean that your patients are not going to get followed up and there are no alternatives, then this is a very difficult dilemma to be facing, and you may need to be using some of those other platforms. But hopefully this is a temporary issue, and when Attend Anywhere is rolled out, which is used in the NHS, particularly in Scotland, I think, quite successfully, this will address this particular issue.
I'm just conscious that Dr. O'Donnell has to go at 2 o'clock. So
I have to give up the room at 2 o'clock, and nobody's here yet. So
so I'm just conscious, has anyone any specific? There's some questions coming in for you, Ava, but there may be more specific questions for Rory. Has anyone got any?
Well, I'm reading the question here from Patricia Walsh. I can address that if there's time. Will I?
Yeah, so, go ahead.
What they're asking about is advanced care directives in the community. So the short answer is, I don't know about the community. I know in hospital, advanced care directives are well thought through. And essentially, the way it works is this. One, we, the medics, we make a decision as to what we feel is most appropriate, whether the patient should be resuscitated or not, depending on each patient. But we don't tend to just act on that. We tend to take that decision to the patient and or to their family to discuss with them. Now, what she's asking here is about patients who might not be able to make their own decisions. They're patients who have impaired capacity. In patients who have impaired capacity, we will tend to discuss that with the patient's family members, who we hope will advocate on their behalf. And 99 times out of 100, we come to an agreement on that. If the patient who has impaired capacity has no family to advocate for them, then we, the doctors, we're supposed to advocate for them and do what's best for them. So every day of the week, we make this type of decision in terms of end-of-life care. Our advantage, though, is that we have in front of us usually a panel of tests, etc., telling us all about this patient and telling us what's going to happen and what the likely outcome is going to be. And very often we know that even if we attempt resuscitation, that we would not succeed. So I don't know what happens in the community. I'm not able to answer that. I would have thought it would be a discussion between the patient's general practitioner and the patient and or the patient's family with each patient. I would have thought that. I don't know. Is that okay?
Yeah, thank you. Ivan, do you want to talk about the isolation and with COVID?
Yeah, absolutely. So there's a draft document that's been compiled with a number of authors involved and quite a significant amount of legal advice. That was put together and completed for mental health settings, and that's been circulated to ECDs and CDs for comments. And actually, once I've signed off from this, I'm going to go on a telecall to look at maybe formulating a similar type of guidance for disability settings. Because obviously, whilst the kind of legal framework is different in the sense that in approved centres, you've got the kind of Mental Health Act elements to consider, there is a significant kind of gap in terms of disability settings where you have issues in terms of engaging the service user sort of adequately with self-isolation. So I think there is a kind of a vacuum of guidance in that particular domain, and that needs to be looked at, and there's a working group looking at that. There was just one other question that came in around the use of CTOs, community treatment orders. And just to say that there has been very significant engagement between the mental health operations and the Mental Health Commission around the Mental Health Act. And there's been a number of emergency sort of elements that have been updated, and that's been circulated to people as well. And I suppose CTOs would have been something that might have been kind of briefly discussed, but at the moment it's not being included in terms of emergency measures. So at the moment it's not being actively considered, but you know the situation is very fluid, and it might be something that comes on the table again at some point.
Great, thank you. And just, Rory, just some clarity on something. Somebody just said in the chat that you were saying about somebody who, from the mental health services couldn't transfer over, I think, to the acute. I think that's Patricia, you were saying. Sorry, can I just go into here to the chat again? COVID positive, respiratory stable, unreliable psych patients can't be discharged from a psych ward. I don't think you were saying that. Just to clear that up.
No, I'm not saying that. I would not be able to make a decision as to who gets discharged from a psych ward or not. So I don't know where that's coming from. I'm not sure where that's coming from. I think if you've got somebody who's COVID positive and who's unreliable in terms of self-isolation, they have to be somewhere. Do you know? It doesn't necessarily have to be a psych ward, but they have to be somewhere where they're looked after and where others are protected from exposure to them. But I think a decision to remain or stay on the psych ward would depend purely on the psychiatric issues at place. But I think in practice, and we had this a couple of weeks ago, is that there may be a patient who was ready for home from a psychiatric point of view, got COVID, and had to spend some fortnight in the general ward in James's in an isolation room because there was literally no option of sending her home because she couldn't self-isolate. So I think these situations will arise.
Okay, thank you. Okay, I think we have answered all the questions there. I think, Ivan, are you happy that we've answered those questions?
Yeah, I think so. And obviously, if people want to come back, if after sort of reflecting on some of the material that's been discussed, people want to come back with any other questions, that would be absolutely fine. And there's also just a reminder for people that there's a specific palliative care webinar that's going to be rolled out sort of later in the week. So that will provide yet another opportunity for some questions and answers in relation to this topic.
I suppose just, Rory, just to end off, in China and the USA they're using robots to swab UV sterilized rooms. Are we anywhere near robots here?
No, unfortunately, no. We have to go in ourselves. What's actually happening in practice is that for each patient, one team member goes in, and it's usually me, to be honest, because I'm the oldest. So one person goes in to the patient and tries to spend the minimal amount of time there. But no, we unfortunately no robots.
Okay, thank you, Kathy.
Yeah, so I think that's a good point at which to end. We're slightly over time, so apologies for that. But I think this has been a really, really informative session. Thank you so much to the speakers. Thank you to the panelists.